again, thank you for inviting me, Farooq. I know that you're on your way, but let's get right into it. The topic of today's webinar is exploring the cardio-renal benefits of peritoneal dialysis. And I thought of a no better analogy than comparing these two complementary therapies as the hare and the tortoise story. The hare or rabbit being the hemodialysis with its fast and furious approach to the way we dialyze our patients. And of course, the tortoise representing the peritoneal dialysis, which is slow and steady and sustained in terms of how it is conducted in our patients. And so in the next 30-40 minutes, what I'm going to try to do is to take you through the so-called putative cardio-renal benefits of peritoneal dialysis. And as we go along, we will add some interesting analogies and anecdotes, if you will, to this whole story about benefits to the heart and the kidneys, which are, as you know, vital organs in anyone, but more so for our patients, because they depend not only on dialysis, but also on, nicely functioning heart and the kidney function. So I'd start with this fable that I think we all are very aware of, and I do not need to go into the story of the hare and the tortoise, but to say that we all know how the hare behaved in the story, and he was always mocking the tortoise, saying, "Do you really ever get anywhere?" And the moral of the story, without going through all of it in detail, is that it is not always the fastest who win the race. I do want to actually highlight the fact that it is not about one therapy being better than the other. But what I'm trying to do is to highlight features of therapies, both in hemo and peritoneal dialysis, that are complementary to each other, but they are also different in some ways. And looking at the differences makes us realize the potential benefits of one therapy versus the other. So remember, the race is not always to the swift. But a little bit of preamble, and that's important to put everything into perspective. And so let me take you back to 1985. And this is a publication from 1985, published by famous nephrologist of the time, Stanley Sheldon and his group, published in Contributions to Nephrology. And one of the remarkable features of this chapter, if you can call that, was the strong and stark statement that was mentioned. And the statement was, PD is a second-rate modality prescribed to second-class patients by second-class nephrologists. And that created a lot of furore over time, was subject of a lot of debates. I remember Annual Dialysis Conference organized some of them, and really gave a lot of people food for thought. But if you really look hard at how peritoneal dialysis has evolved over time, you can actually divide it into 5 major time frames. We have the pre-20th century era, way back when Egyptians actually realized that peritoneum or the peritoneal membrane could be used for peritoneal lavages. And then, of course, we know about 1920s when the German nephrologist Ganter used peritoneal membrane for dialysis. And then came the Second World War and the post-war period when, with the Korean War and the World War just ending, there was an urgent need recognized for finding a proper treatment for kidney dialysis, and people started dabbling in various forms of therapy, hemo and PD. And then came these 2 decades of growth in PD technology, decline in infection rates, and so on. But then the use stagnated between 1990s and 2010s across several countries, not all of them, but several countries saw a plateauing the use and uptake of PD patients. And now we come to the present, when re-emergence of PD therapy is being seen everywhere, primarily to improve patient-centered care or the other benefits that we'll talk about. With that as a background, let's look at what's going on. This is USRDS data, looking at prevalent patients on different modalities. And so what you see here is that our hemodialysis patients generally go on top of the list. Somewhere close to 60% or so prevalent US population is on hemodialysis. And when you look at PD, it comes at number 3, the second one being transplant. So PD still is not where it ought to be in terms of penetration and offering renal replacement therapy to our patients. If you look at the incident and prevalent rates, again from USRDS, the latest ADR, you can see that the incident rates on PD are generally about 14%, which is better than before, but not where it needs to be. And the prevalent population, again, is close to about 12%. So a lot of work needs to be done. Despite the fact that when you compare the cost of PD, at least in the developed world, hemo is the more costly or expensive therapy. The question then becomes is, it is all fine and dandy that PD penetration is not where it should be, but what about how we have done with PD? So the question is, have we really made a difference in clinical outcomes? When we look at patients from, let's say, late 90s to 2015, and this is just one of the many papers that has looked at it, at cohorts starting from 96 to 2014, using patients who had been on PD for at least one day. And this is Medicaid data. And what they reported, without belaboring it a lot, it was published just very recently in Kidney Medicine, the death rate has declined significantly. The transition rate to hemo has declined significantly. And when they looked at more recent cohorts, for example, a 3-year follow-up of cohorts starting in 2008, they found a really significant decrease in transition to hemo and decrease in risk of death. This was more pronounced in larger programs, which is not a surprise. And then, of course, the length of PD had an opposite effect in terms of increasing risk of death and increasing risk of death and transition to hemodialysis. I think this is one of the more important papers that we need to look at. Published in 2011 in Annals, in Archives rather, which essentially looked at and compared different cohorts in terms of survival on PD, comparing it to hemodialysis. So they took 96 to 98 cohorts, 99 to 2001 cohorts, and 2000 to 2004 cohorts. And they looked at the median expectancy on PD, median life expectancy on PD and hemodialysis over these cohorts. And what they found was that when they looked at the cohort as a whole, in terms of overall months of follow-up, there was no difference in median life expectancy of PD and hemo patients. So much for survival. We have seen that the clinical outcomes have improved over time with adoption of new technology, new solutions, better education of nephrologists, but also the survival by and large is no different than hemodialysis. So this 1985 statement of second-class nephrologists giving second-class therapy to second-class patients is not valid anymore. And survival on PD is closely linked to one of the key determinants of survival, which is residual kidney function. And the first signal that residual kidney function is very important and has a direct bearing on survival came from the reanalysis of CANUSA data several years ago in the 90s, when John Bargman showed that each 5 liters a week increase in residual GFR is associated with 12% decrease in relative risk of death, And likewise, they found and reported that even 250 ml increment in urine volume is associated with 36% decrease in overall mortality. NECOSAT data from the Dutch group demonstrated essentially the same positive outcome in terms of the benefits of residual kidney function. And so this became very important as one of the key determinants of survival on PD. The question then becomes is how do we improve outcomes in PD? And that's a very important question that we need to tackle. And I'm drawn to one of the people I really admire, the wit and wisdom of Charles Munger. I don't know how many of you are aware of this gentleman who recently passed, but essentially Charles Munger was a business partner of Warren Buffett and vice chairman of Berkshire Hathaway. And his theory was that when you're trying to solve a problem, which is a difficult problem, in this case, of course, how to improve outcomes in PD, he always propagated a mental model that basically said, invert the problem, look at it backwards. And this inversion theory was, in fact, really emphasized for the first time by a German-Prussian mathematician by name of Jacobi in 1830s. And what he said was that when you're trying to figure out a problem, try to look at the inverse of the problem. Try to turn it upside down and see what made it happen, what made the whole situation go upside down, and then try to avoid those things. And so this is one of the famous lines of Charlie Munger, who said, all I want to know is where I'm going to die, and then I'll never go there. So in other words, he will avoid going where he's bound to die. And in other words, live and live forever. One of the other ones was, it is easier to avoid stupidity rather than seek brilliance. And so one of the examples is if you have an aeroplane, a fighter plane, and you're trying to make it operate efficiently, and it's going towards a target in a fast way, efficient way, and it's moving towards a target. You want all those things to happen and want the plane to return safely to the base. So how do you do that? Well, one of the ways, according to this theory, is imagine the plane turning upside down. And then try to look at things which made it upside down. And then try to avoid those factors. And that is the law of inversion. And that will bring, that's kind of interesting because that's very relevant to the problem that we are trying to address today, how to make PD better, or rather how to avoid adverse outcomes in PD. And we'll touch upon this a little more. So the question coming back to PD is, what drives poor outcomes on PD? Well, if you think about it carefully, the poor outcomes in PD are essentially, besides, of course, other non-medical factors, are determined, as we've seen, by residual kidney function, but also what happens to the peritoneum. And lastly, of course, the Achilles heel of peritoneal dialysis, as we all know it, the infections, right? And so, coming back to the inversion theory, how can we improve outcomes? Well, adopt measures which really lead to poor outcomes. In other words, preserve residual function, protect peritoneal membrane, and prevent infections. The question then becomes is, it's all good about PD in terms of residual kidney function. How important is residual kidney function on hemodialysis? Well, we know that from a lot of observational data and studies from the Dutch group and other studies like CHOICE study, that hemodialysis is also one of the modalities where preservation of residual kidney function is extremely important, even though we haven't paid much attention to it. And more recently, some more data has come about that has examined this in a little more detail. And this is one of the few reports that has looked at residual urine output and mortality in a prospective hemodialysis cohort. These are 670 patients across 17 dialysis centers looking at all-cause mortality risk based on the presence of urine output and frequency of urine output, which was self-reported. And lo and behold, again, both at baseline analysis and time-dependent analysis, it was reported that in hemo patients, there's a graded association between lower frequency of self-reported residual urine output and higher mortality risk. Not only that there's an overall all-cause mortality risk, people looked at all-cause mortality in residual kidney function in hemo patients, looking at a much larger database of almost 40,000 patients, looking at collected data on urea clearance and urine volume between 2007 and 2011 in a longitudinal cohort study, and again found that there was increased cause-specific mortality when urea clearance, kidney urea clearance, fell than less than 3 mils a minute per 1.73 meters square. And interestingly, the risk was attenuated by adjustment of ultrafiltration rate, not surprisingly, because as you know, if we pull the ultrafiltration too hard, we compromise the residual kidney function. Again, highlighting the fact that cardiovascular mortality in this case is closely associated with lower residual kidney function and loss of residual kidney function. So that said about residual kidney function, we'll come back to that. Let's now move from the preamble to what I would call the heart of the matter. So this is the outline of the remaining part of my talk. We'll talk about the enhanced cardiovascular risk. We all know it exists, and then quickly switch to two major important components of the talk. One relates to what happens to hemodialysis. What is the so-called dark side of hemodialysis, using the inversion theory that we just talked about, and then talk about residual kidney function in both modalities in a more expanded way. So let's talk about what's going on in the heart of our patients. And this is a slide that was first prepared by Rob Foley that essentially tells us a very, very remarkable story about the cardiovascular system morbidity and mortality in patients on dialysis. So what you see here is annual mortality on the vertical axis and the age of the patients on the horizontal axis. And so the light blues are patients who are not on dialysis. They are distributed according to, race and sex, male and female, colored and white. And on the top, in the dark blue lines, are patients who have ESKD. And so the first thing that becomes obvious is the fact that patients in the 25 to 34-year age group, relatively younger people, have, this is a logarithmic scale, by the way, have 500 to 1,000-fold higher cardiovascular risk at that young age when they are on ESKD, which is comparable to an 85-year-old gentleman or a lady in general population. So extremely enhanced cardiovascular risk, even at a relatively young age. And that is something to bear in mind, that cardiovascular risk is a major determinant of how our patients do long term. And this is borne out by USRDS data, where if you focus on causes of death, both in hemodialysis and PD, this green pie bar essentially is representing the cause of death of both hemo patients and PD patients. And most of it is driven by sudden cardiac death and arrhythmias. So cardiovascular death is a big player here in terms of determining outcomes. Let's now move towards hemodialysis and its impact on the cardiovascular outcomes. So you may be thinking, why am I talking about hemodialysis when the whole discussion is about PD? Well, when it comes to looking at the interaction between PD and the cardiovascular system, I'm once again drawn to this mental model of inversion. In other words, if we look at the harmful effects of cardiovascular on cardiovascular system that are caused by hemodialysis. And the fact that the peritoneal dialysis modality avoids such effects, the relative benefits of peritoneal dialysis become apparently pretty easily obvious. So for the next few minutes, what I would try to posit or put before you is to examine what really happens to the cardiovascular system in a hemodialysis situation. Or inverting it, how does PD avoid those harmful effects? Well, Chris McIntyre, a good friend of mine he worked in St. Bart's in London and then moved to, Canada, and borrowed a few slides from him because he's done some remarkable work on highlighting what is called the dark side of hemodialysis. And one of his slides depicts hemodialysis in a very stark way. And he goes on to say, dialysis is awful. It's awful because it drives multi-organ injury, largely through recurrent ischemia, and then goes on to discuss the pathophysiology of hemodialysis. And he talks about one of his patients that we all encounter on a day-to-day basis, in that patients arrive pink, talkative, and happy, and would leave pale, gray, and silent. And then one of his patients mentioned and put it in clear and stark terms. He said, I understand why I need dialysis, but how can something that makes me feel so terrible not be hurting me? And that gives us a lot of food for thought about a physician's perspective and a patient's perspective about life on hemodialysis. Well, this is a typical scenario in a common unit, hemodialysis unit. We all have seen it in some form or another, and basically at some point in our lives. And this is a very distressing situation, and it happens for a reason. And let me take you through some of those. So the two common pre-dialysis stereotypes when they come to the hemodialysis unit. We have the so-called good patient. Who's this patient? He has less interdialytic weight gain, is easy to manage on dialysis, he's cooperative, he's compliant, generally symptom-free on dialysis, requires a very low ultrafiltration rate, meaning not above 1 liters per hour. Blood pressure is well controlled, little changes in blood pressure during dialysis. He is a so-called dream of a dialysis nurse. On the other hand, we have the bad patient. Again, the bad dialysis patient in quotes, who has high weight gains in between dialysis, very hard to manage. He's labeled often as uncooperative, non-compliant, very symptomatic during dialysis, has cramps, has so-called dis-ease during dialysis, runs a high ultrafiltration rate because he needs it. Blood pressure is poorly controlled, blood pressure is unstable, crashes during dialysis, and to put it briefly, he's a nightmare to manage by dialysis nurses. Well, why is this all going on? And this becomes apparent when we think about what is happening during a 4-hour or 3-hour dialysis. We are trying to remove, depending on patient to patient, 2 to 5 liters over 3 to 5 hours, generally 3 to 4 hours. This amounts to almost 1 to 2 times of plasma volume being removed, assuming that average approximate plasma volume is 3 liters. So you remove 1 to 2 times plasma volume in a finite time frame of 3 to 4 hours. So obviously things don't go wrong, because where is this all fluid coming from? It is coming from this phenomenon of known as plasma refilling, the interstitial space. So when we're trying to remove, and this is just a cartoon to explain that, the red being the vascular space and the yellow being the interstitial space, when we're trying to remove plasma volume from the vascular space, the fluid has to come in from the interstitial space. But there are things that impact this plasma refill. One of the things is the hydrostatic pressure within the vascular compartment. So if you have, or patient has cardiac dysfunction or peripheral pooling of blood volume, obviously the refill rate will be lower. If the interstitial volume is depleted, on the other hand, because of whatever reasons. Some of them are pointed out here: high ultrafiltration rate, incorrect assessment of body weight, high transcellular urea gradient, low dialysate sodium being some of them. The driving force will obviously not function. And then, of course, in patients who have low albumin, because of the fact that oncotic pressure is low, again, refill rate suffers. So without belaboring the point of plasma refill rate, let's just look at some numbers. In stable hemo patients, the mean maximum plasma refill rate based on some mathematical modeling is generally about 400 ml per hour. And so when you go up in the ultrafiltration rate beyond 400 mL per hour, blood volume will fall. If you go down, blood volume will relatively remain intact. And so it all becomes a question of balancing fluid out and fluid in so that you can keep pace with the ultrafiltration with the plasma refilling. Now put that in context of what happens in PD. This is the temporal profile of ultrafiltration force in PD, which is obviously the net of the transcapillary ultrafiltration that happens, but simultaneous lymphatic absorption that happens, resulting in net ultrafiltration. If you transpose that phenomenon in, let's say, a high average transporter using different solutions, so we have a 1.5% dextrose, a 2.5% dextrose, 4.25% of the strong bag, and of course icodextrin. What you see here is the ultrafiltration amount removed over a 4-hour cycle is much lower as compared to what we do in hemodialysis. In other words, ultrafiltration rate, there is no comparison between hemodialysis and peritoneal dialysis. Again, bringing or reminding us of the slow and steady and sustained ultrafiltration seen in PD, or the tortoise in our story. This rapid ultrafiltration in hemodialysis has many consequences, and one of them is intradialytic hypotension. And that happens for a variety of reasons, one of them being too rapid removal of fluid because of high interdialytic weight gains. So the two types of intradialytic hypotensives that we see generally, one of them is a slow glider. So as the fluid removal increases during dialysis, the blood pressure starts to fall and keeps falling over the duration of dialysis. But then there's the other one, the cliff faller, who are doing generally okay, and then they fall from the cliff as all hell has broken loose. And the remarkable thing is that in these types of patients, there's no sudden removal of excessive volume right before the hypotensive episode. It is driven more by what happens to the cardiac filling. There is sudden sympathetic failure, which essentially drives the movement of blood from the splanchnic circulation to the right ventricle, and so that there's no forward stroke volume to begin with because of this lack of filling. Beyond hypotension, there's another phenomenon which is known as myocardial stunning, which happens during hemodialysis. Again, very extensively studied by Chris McIntyre. And this whole study was begun in 2006. This is a diagram from his original memoir, where a hemodialysis patient, while on hemodialysis, was put in a PET scanner to examine what was happening to the heart during hemodialysis. And what they found and reported in multiple papers after that was very interesting, in that as soon as hemodialysis starts, and this is cardiac findings at baseline at 4 hours and post hemodialysis, regional wall motion abnormalities start to appear in the way contractile function of the heart is taking place, both at baseline and then, of course, enhancing during and after dialysis. And so much so that if you remove 1 liter of ultrafiltration over a 4-hour session, there's a 5 times higher risk of stunning. If you remove more, the risk enhances in a much higher proportion, 26 times higher risk. And over time, if these myocardial stunning phenomena continues to happen, it gives rise to what is known as wall motion abnormalities, leading to heart failure over time. So this is something that is to be avoided, but obviously better is easier said than done, especially in center 3 times hemodialysis. And so to examine the role of circulatory stress in a little more defined way, and the whole phenomenon of end organ ischemia, Chris McIntyre used dynamic PET monitoring and MRI scanning to look at what happens to organs in the situation of hemodialysis. And what he reported in subsequent papers was very interesting, in that the ultrafiltration volume, as it goes up, the risk of myocardial stunning goes up. And likewise, when the blood pressure drops, the risk of myocardial stunning again is enhanced. So these are number of stun segments shown on the horizontal axis, and the lower BP shown, or lower mean arterial pressure shown on the vertical axis. As the mean arterial pressure falls, the number of stun segments actually goes up, and likewise, as the ultrafiltration rate increases, the stunning increases. What about the brain? The similar phenomena going on in the brain. Ischemia due to reduction or acute reduction in cerebral blood flow leads to cytotoxic edema. And this is a multi-dimensional pathway mediated through inflammation, ischemia, and of course, oncotic stress, all of which lead to edematous capillary endothelial cell edema of the astrocytes, which in turn leads to findings in the brain that have now been very well documented. And this is just one representative labeled MRI image of what happens to human brain during a conventional 3 hours of hemodialysis. To your left is the brain, which is before dialysis, and what happens to hemodialysis at 3 hours. Remember, the red color represents a blood flow to the brain, which is functioning well at the start, and then at the end, you see all the rapid disappearance of this red color. And so when you try to do the representative MR imaging, you can see these yellow, blue, and green lines, which essentially demonstrate the regions where fractional anisotropy and diffusivity increases, telling you that cytotoxic and vasoactive edema is happening. The interesting thing is that these insults to the heart and the brain, and of course to kidneys, as we shall see, are recurrent. So the injury is cumulative. In fact, at the brain level, it is universal and progressive, and primarily affecting the subcortical white tracts. And they have been found to be independently associated with hemodynamic instability. So the white matter or the subcortical white tracts are like the internal wiring of the brain and are related to executive functioning, decision-making capabilities. So patients have cognitive issues, decision-making issues over time that is very well recognized. And when you try to examine that in more detail, there are multiple pathways that actually drive these cognitive dysfunction in hemodialysis. In PD, not so much, because the factors that drive cognitive dysfunction in hemodialysis are not operational to the same extent in PD. This white matter injury and to some extent cortical injury in PD is driven by endotoxins, primarily by the intramural translocation through the gut, and of course, to some extent, by advanced glycosylation end products that we will allude to in the later part of my talk. So these cycles of aggravated injury lead to what is known as dying to feel better, the dialysis-induced tissue hypoxia that happens at multiple organ levels. at the level of the brain, as we just saw, at the level of the heart, at the levels of the gut, at the level of kidney, all driven by this fast and furious pace of 3 times a week hemodialysis. Now, if you pause here a bit and try to visualize the temporal profile of ultrafiltration, try to imagine, what else is going on in hemodialysis that doesn't happen in PD. We can visualize all those negative things that are happening in hemodialysis being spared off in peritoneal dialysis. And that was the whole point of going through the various dark sides of hemodialysis that we do not often think about. Let's come back to dialysis and kidney function, the residual kidney function. Again, a very key determinant for success of PD and, of course, hemodialysis in general. So dialysis and kidney function are vastly different. You may say, well, as compared to normal kidney function, as is shown here in terms of small solute clearance like urea and creatinine, and also in terms of a larger solute clearance like inulin, when you have normal kidney function and then when you have dialysis, hardly much remains. So dialysis in general is providing about 8 to 10 or 12% of what kidneys do on a 24/7 basis. But even at GFR of 10 mils a minute, which translates to 10 liters a week, there are certain things that kidneys do 24/7 that dialysis cannot. And that is shown here. One of them is dialysis cannot remove protein-bound toxins, even at those low levels. And also, the selectivity of removal of toxins suffers because of the very nature through which the kidneys work as compared to how dialysis membranes work, as is shown to your right. So selective removal of toxins suffers, removal of protein-bound toxins suffers, even at low levels of GFR or residual kidney function that we see in our dialysis patients. And there are additional benefits of residual kidney function on PD, which are shown here, including of course, improved volume status because of the fact that if a patient is excreting 500 ml or more per day, less ultrafiltration needs to happen, better blood pressure control, lower left ventricular mass, reduced exposure to glucose that we'll come back to, lower peritonitis rates, decreased hyperglycemia and weight gain, nutritional status is better, dietary restrictions are better, there's some reports of better quality of life, reduced erythropoietin requirements, lower inflammatory markers, and of course, the whole mineral bone disease issue that is less severe in patients with preserved residual kidney function. Well, what about hemodialysis? Again, hemodialysis causes a lot of things that adversely impact residual kidney function, as is shown here, by causing hypoperfusion and reduced ability of chronic kidneys to auto-regulate. It causes reduced osmotic load, which is a major driver of urine output, especially when you're talking about patients on dialysis. And of course, it causes cellular activation and aggregation. So platelet activation by heparin, by extracorporeal circuit, dialyzer membranes, microbubbles, all of those contribute and impact residual kidney function. And here are some predictors of loss of residual renal function, some of which are common to both hemo and PD, some are common only to hemo, as is shown in the lower panel. But be that as it may, there are certain predictors that you cannot change. There are certain predictors that you can. And in hemo, I've already pointed out things like hypotension and of course, frequency of dialysis. But in PD, there are other factors that we'll talk about. Interesting to note is also the fact that when you look at preservation of kidney function in hemo and PD, study after study has shown that peritoneal dialysis patients preserve kidney function for a longer time as compared to hemodialysis. And that is something to keep in mind as we go through this whole concept of beneficial effects of PD and hemodialysis. Let's come back to the peritoneum, because that's where we began as one of the key factors besides kidney function in terms of protecting it so that things don't go south in terms of how we want our peritoneal dialysis patients to perform over long term. Infection is a different story, and we don't have time to go over how to prevent infections, but let's confine to RKF and peritoneum. So what about peritoneum? Well, let's look at what's going on. This is the mesothelial, this is the endothelial side, and this is the peritoneal side of the peritoneal membrane. These are the mesothelial cells. This is the peritoneal cavity. This is the submesothelial compact zone. And then, of course, at the lower end, shown at the very bottom, are the deeper, looser adipose and connective tissues. So this is a quick refresher to the peritoneal membrane and the peritoneal cavity. Now, let's look at what's this story with glucose, because glucose, especially chronic glucose exposure, is toxic to the peritoneum. If you think about it, how does glucose impact? Well, first of all, it gives a patient a lot of calories. So here are two representative bags. Medium bag, which is, depending on where you live, it's a 2.5% dextrose or a glucose in different constitution. And so this is 4.25% dextrose. This is 2.5% dextrose. And essentially, when you look at it, the amount of absorbed glucose gives you calories, either 156 in a medium bag and 264 calories in a strong bag, which is 2.27% glucose or 3.86% glucose in UK terms and European terms. So these are a lot of calories. On an average, a PD patient gets about 300 to 400 calories absorbed, causing a lot of issues, including hyperglycemia, including hyperinsulinemia, which has obviously multiple downstream effects. But beyond calories, beyond sugar load, a lot of other things are happening. And one of the key factors that is happening, especially with the use of conventional glucose-based peritoneal solutions, is the phenomenon of what is happening at the peritoneal membrane level. So what you see here highlighted by these digits 1, 2, 3, and 4 represented at the peritoneal membrane level, you are losing mesothelial cells, you're leading or propagating interstitial fibrosis and peritoneal thickening, you're causing neoangiogenesis and vasculopathy. So think about the diabetic retina. There's vascular proliferation, the same thing in diabetics, and the same thing is happening here at the peritoneal level. There's increased vascularity. And of course, the number 4 is the accumulation of advanced glycosylation end products that have a key role to play in inflammation. As a result, in a very recent paper, Dr. Credit has very spectacularly pointed out what happens by accumulation of these bad actors like myofibroblasts inside the peritoneal membrane. So on top is the gradient, the crystalloid osmotic gradient imparted by dextrose or glucose for movement of fluid from the vascular compartment into the dialysate compartment. And you can see the crystalloid osmotic gradient represented here by this black arrow. Osmolarity of the dextrose and intravascular osmolarity. You can see the gradient is pretty stable. But what happens over long term in that these bad actors have come into the peritoneal membrane and they have started to eat up a little bit of glucose. and so this gradient declines. The osmotic gradient that we see declines. As a result, the ability of dextrose solution to remove fluid suffers because of these peritoneal changes that we talked about. And so that behooves a question, how can we make a difference? Well, obviously, using less dextrose makes sense. And that brings us to this whole concept of PD solutions, which are more biocompatible. So they have not only less glucose in the example of iodextrin, which is not classically a biocompatible solution, but biocompatible solutions in terms of a more neutral pH, because pH, the acidic pH, is not good for peritoneum. And of course, less glycosylation advanced products, which are obviously not only toxic to the peritoneum, but also toxic to the vascular health, as we have seen previously. So there are some points in favor of biocompatible PD solutions when you weigh the evidence. And of course, there are some points that are against it. But be that as it may, let's look at one of the important trials that was done called the BALANCE trial that used a pH neutral solution with low GDPs in it. And in terms of preservation of residual kidney function, it reported a couple of important findings. Even though the slope of decline of GFR was not different between the two arms, the time to anuria was longer in the biocompatible based arm. So that was one key message. The other key message was that because of the fact that the longer time to anuria was seen in the biocompatible group, what could be driving it? Well, was it the low GDP load, or the fact that the reduced peritonitis risk seen in biocompatible arm in some ways contributed to the longer time to anuria? Or was it just because these patients were relatively volume expanded, and that volume expanded state drove the preservation of kidney function to a longer time frame? But all things being said, it is generally recognized, for lack of better evidence, let's say, that biocompatible solutions possibly have beneficial effects in preservation of kidney function for a longer period of time. And that brings us to the final question. How do we preserve kidney function in a PD patient? Obviously, preventing peritonitis to your left is a worthy goal. Biocompatible PD solutions is obviously important. Studies have shown that if you use renin-angiotensin-aldosterone axis inhibitors like ACEs and ARBs, you end up with better preservation of kidney function. In dialysis patients, we saw the detrimental effects of hypotension and volume depletion in hemodialysis, and that does not happen that frequently unless we allow the patient to get dehydrated. And so that has a role to play. Optimizing blood pressure, avoiding nephrotoxic drugs, pretty obvious, and minimizing or judicious use of radiocontrast is another thing that goes a long way in preserving kidney function. So I would like to close by highlighting the fact that thinking in a reverse way is extremely important in any difficult situation, PD being a good example. We talked about the cardiovascular risk factors and other things, but we still struggle with the fact that PD remains underutilized despite comparable survival, with hemo, despite the fact that if you look at the data, we have remarkably improved in not only survival, but also in technique failure. We discussed the relative importance of residual kidney function in PD and of course in hemo as far as survival is concerned. We talked about the basic role of peritoneal preservation. We talked about the relative benefits of PD vis-a-vis hemodialysis and preservation of residual kidney function. Not to forget the dark side of hemodialysis and the multi-organ ischemia that hemodialysis entails, and the fact that preservation of kidney function and protecting peritoneum are key to improving outcomes when viewed with the inversion theory that we talked about. And then on a more happier note, in the present day and era, from 1980s, we have come a long way, and PD is now re-emerging as a dialysis modality with a renewed focus on patient-centered care. And I'll close here and thank you for your attention.
Well, Madhukar, thank you very much for a comprehensive review of and comparison of PD and hemodialysis. As I see your slides, it points out all the key points that Byonyks is actually working on in terms of biocompatibility, reduction of glucose exposure, glucose degradation products. The list goes on and on of the things that are going to be incorporated in some of the X3 developments of Byonyks. But I do have one question for you. Can you speculate on why the survival rates of hemodialysis and PD are comparable? Because you make a strong case that there may be some cardiovascular benefits of peritoneal dialysis versus hemodialysis, and yet bottom line, in terms of mortality, they're roughly the same. Maybe PD is now pulling ahead a little bit, or especially early on, probably related to residual renal function. But can you speculate on why it's not more compelling?
Yeah, and more so because if you look at the causes of death, the cardiovascular disease emerges as a common factor in both, right? And so the question then becomes is, what is going on that despite all the benefits that I touted for PD in terms of the dark side of hemodialysis not happening in PD? I think it has got a lot to do with the fact that the die is already cast for cardiovascular death, even before our patients go on dialysis. In other words, the damage has already been done. The patients who go on dialysis are the so-called survivors who made it through stages 3 to 5 and ended up on dialysis. And so when you look at the detrimental cardiovascular effects of hemodialysis, not to belabor the point, hypertension, toxicity of the procedure itself, and multi-organ ischemia, PD has a slightly different angle, but it does have its own issues, fluid overload being a big issue, and of course hypertension being a big issue, and a slightly different detrimental effects in PD as compared to hemo. One of them is mediated more by metabolic effects rather than the hemodynamic effects. And those metabolic effects, again, I highlighted the problems with hyperglycemia, hyperinsulinemia, high blood pressure. There's data that talks about the altered baroreflex sensitivity seen in PD patients. Of course, it's seen in hemo patients too. In fact, in hemo patients, the whole concept of volume removal and the inability to generate a tachycardic response is because of the insensitivity of the baroreflex, because they behave as if they are beta blocked. And in face of volume removal, they do not respond with the tachycardia that a hypotension would behoove. Likewise, in PD, there's problems with autonomic neuropathy that guides to a large extent over time what happens to bad outcomes in terms of cardiovascular outcomes. And then, of course, there's data, again, from Chris McIntyre's group studying what happens to the cardiovascular hemodynamics in PD. And one of the things, this was a small study, which showed that even though, and this was, I believe, in 10 patients, McIntyre showed that the phenomenon of changes in myocardial stunning do not happen with a single strong exchange, in that the echocardiographic changes of wall motion abnormalities do not or are not seen in that 10-patient study. But he does go on to say when he studied APD patients that you instill volume in these patients, there is rise in pressure during that cycle. and goes away when you drain the fluid. And so he postulates that maybe that is one of the factors that while the time the patients are doing exchanges, there's rise and fall of blood pressure that may have something to do with altering the cardiovascular physiology seen long-term in our PD patients. So the answer to your question, again, is the question is extremely important, but the two key points that I would like to put forward, one of them is the die is already cast. We know for a fact that the classic cardiovascular risk factors, high cholesterol being one example, are not so much operative in our dialysis patients as they are in the general population. And the second fact that most of the damage that had to be done was already done, and these patients who went on to dialysis are the ones who survived despite all that damage. And the second has to do with the fact that the stress that the dialysis modalities impose on our patients who are survivors to begin with differ in certain ways. Hemodynamic in the case of hemodialysis, metabolic and autonomic in the case of PD.
Thank you very much, Dr. Misra. It was an excellent talk. And my question is, one of the factors, as you mentioned, there is an already dies cast, and one of the factors is the mineral bone disease. Now, what are the important factors that we need to look at in terms of the peritoneal dialysis patient compared with the hemodialysis patient in managing this issue so that we can decrease the overall mortality?
Yeah. So again, some of the factors are common when you're talking about arterial calcification. We are talking about systolic hypertension due to calcification of the blood vessels, which are common both to hemo and PD. Secondary hyperparathyroidism, the adverse, in fact, more important risk factor for cardiovascular outcomes now is not, the conventionally taught high parathyroid levels or the high phosphate levels. It is the FGF23, which again is common to both. But coming back to your question, I think one of the important key factors, especially in the case of PD, is the advanced glycosylation end products, which are arising out of GDPs. And to somehow minimize that from getting deposited to the vascular walls of our PD patients, and of course hemo patients to a certain extent too, because they also have been shown in experimental models to increase arterial stiffness. And as you know, that vascular health, insofar as it relates to stiffness of the vessel walls, be that as it may for large vessels, it's also important for the smaller vessels, because arterial stiffness at the end of the day is not good for organ perfusion and also not good for systolic blood pressure. So I think that's one of the key factors. And again, as Dr. King pointed out, lower GDPs, and the story of GDPs is not over. And the whole idea about being able to alter with modern therapies in terms of GDP load that we offer to our patients has a tremendous potential in terms of advantage to our patients.
Well, I think, Naman, in courtesy to Dr. Misra, we are at the end of the hour, and probably we should funnel some of the other questions to him so he can answer them at his leisure. So I'd like to take this opportunity to thank you for a great talk. I mean, that was really provocative, and lots more questions I would like to ask you. And we hope to have you back sometime in the future. Naman, you want to make any final comments?
Yes, thank you very much. It was quite detailed and elaborate discussion about why we should be choosing PD. Particularly the cardiovascular mortality is the bottom line for any kind of modality or treatment that is offered to our patients. And just while winding up, can we answer this quick question? Somebody asked that, what would be the 5 points that you would say that were simple points why we should be on PD? More than the hemodialysis for our patients.
I don't know about 5 points, but I can speak to many points. One of them is, let's keep the medical aspect aside because we already talked about it, right? It's a gentler therapy. But I think depending on where you live, a lot is driven by the logistics of your place of work. Having said that, if you think about PD, if you think about what is coming into the market, if you think about the ease of therapy, if you think about the lifestyle, and especially in the elderly population, if you think about not traveling back and forth to an in-center unit, spending almost 8 to 10 hours of a day, and coming back to your home to sleep, feeling as if you've been put through a washing machine.
Exactly.
It makes you pretty obvious to anyone that PD is probably the way to go. Now, obviously, there are certain things that have to be taken care of, and that brings us the question of what about patients who cannot do PD at home for a variety of reasons? They don't have a caregiver, they don't have enough space to store the bags. They're not comfortable doing the therapy themselves. The therapy is too complex. Again, newer technology is going to address all of these factors. But I think the top few factors, besides the logistics, besides the medical factors, are the ease of therapy, the independence, not being required to travel to a distant location where you're surrounded by unknown faces, and of course doing at your own leisure. So these are some big benefits apart from, of course, preserving kidney function, which is a big driver that has only been recognized in last 20 to 30 years. Long term, yeah. Sorry,
Please,
as I
please.
said, I could go on and on, but I'll shut up here.
Yeah.
Thank you so much. I think we'll have many questions and maybe few more sessions in the future, and we can discuss with Andy and yourself and other our partners that which topics are to be covered, and so that we can move forward in our project in terms of providing a better dialysis for our patients and a better healthy life. Thank you.
Thank you. Thank you so much. I appreciate your
Thank you.
kindness and nice words. Thank you. You all have a good day.
Thank you.
Bye.
Bye now.
Bye. Thank you very much.